Abstract is home NG tube feeds are safe and do not lead to additional morbidity or late gastrostomy placement in premature infants born at a rural academic hospital by Dr. Reto Bertscheiger.
Hi, everybody. It's my pleasure to present on behalf of our medical student, Karina Lukovic, who has a very stringent preceptor on internal medicine and could not be here. And she went to PAS in Honolulu and wants to be a pediatric subspecialist, so I don't fault her for unfortunately not being here today and having me up here with more gray hair and less overall hair than every time that I was up here in the past. So I have no disclosure. We did a pilot study in our rural medical center to show that some of our preterm babies can actually go home with an NG feed in a rural setting, and that they can be taken care at home while getting monitored and having all that data centrally reported and monitored and watched. It allowed us to create some early discharge programs and decrease morbidity, potential cost, and invasive procedures within our NICU. Now the question is, which patient will succeed in such a program on a bigger scale? And is there any differences between the setting of their homes, whether socioeconomic status or pregnancy, like multiple pregnancies or not? So the purpose of our study was to determine the safety and feasibility of home NG tubes in a cohort of premature infants born in a rural center, and then to further analyze if there's any other cofactors, including the Children's Opportunity Index, that may affect the success of NG tube in this cohort and the duration of them. So our methods, it's a retrospective chart review of prospectively enrolled patients. We included 100 premature infants consecutively enrolled at our center, and we call it the HGH program, so Hope Growth at Home, and they were prospectively enrolled from July 2020 to November 2023. We had all their data, meaning pulse ox, saturations, and heart rates recorded centrally through monitoring and have a telehealth capacity to support them. We recorded demographics, the gestational status, distance to our hospital, the Children's Opportunity Index, based on zip codes and other clinical outcomes, meaning the NG duration and complications. The statistical analyses are as you can see there. So just a quick mention about the Children's Opportunity Index. For those who are not familiar, it's a multidimensional measure of neighborhood conditions associated with health outcomes, and it includes education, health and environment, and socioeconomic status. And we used the 3.0 from 2021 to do that. We live where the little star is, in Lebanon, New Hampshire, and we have patients from all over the states between Vermont and New Hampshire, which are obviously pretty rural. And the results, so we included, from the 100 patients we initially included, we have data on 96 patients, 59% were female. The mean gestational age of patients was 33 weeks. Their birth weight was 1.91 kilograms, and they lived more or less 50 miles from the hospitals. We included 16 patients from multiple gestations, and only 3 out of the 96 patients we have data from eventually required gastrostomies. 3 were readmitted for reasons not related to their NG tube feeding, and 1 death was unrelated to feedings. You can see on the table that from a Children's Opportunity Index, we have mainly high to very high. However, moderate and low are not underrepresented so far, and the overall NG tube feed duration was not statistically significant between the groups. Obviously, higher gestational age at birth was significantly correlated with reduced NG duration, which is not a surprise. There's no significant difference in NG feed duration between multiple gestations and singletons, and the Children's Opportunity Index status was not significantly correlated with NG duration and readmission rates. Just to show you on the map, so on the left, you have the number of patients by zip codes, and you can see that some are coming almost closer to Montreal than to our center from the Vermont-Canadian border. And they're all over the map, even from the southern part of our state, which would be closer to any Massachusetts hospitals. And then NG duration by zip codes, there is also a wide distribution. And I don't know what's happening on the east side of our state with the red, which is the highest duration, but there was a cluster there. And you can again see superposition of the Child Opportunity Index, which rural places are more deprived than overall the academic center area or more urban areas. So our program can be show that we can be safely implemented for preterm infants of multiple gestation, home NG feeds are feasible and safe for infants from diverse socioeconomic areas and in rural settings. I think it allows these families to go home, have their children with them at home, and avoid the financial and potentially emotional strain of prolonged hospital courses. Though our limitations, it's a single center, prospectively collected data, retrospectively analyzed, and it's only categorical data. So in conclusion, our Hope Grows at Home program has safely discharged over 100 premature infants since we started the program with NG tubes in rural Vermont and New Hampshire. Only 3 ultimately required a G tube, and 93 patients were on full oral feed, at the end of the program, potentially avoiding G tube placement and its morbidity, and certainly avoiding the risk of prolonged NICU stays, including the exposure to infections, stress, cost, and everything that comes with it. The distance to the medical center and the Children Opportunity Index did not correlate with length of NG feedings or complications. Our next steps is to look actually at the heart rate variability and those 2 saturations to see if there's any prediction that we can get from these patients. Only having 3 G tube placements, our study is going to probably be underpowered to make any predictive analysis, and then we'll also do a cost analysis. We collaborate with the engineering school as well, and we will be looking into the CO2 impact of the travel of these families or the prevention from that. Thank you very much, and again, this is the work from Karina and the NICU team and the surgery team at Dartmouth. You can see we live rural. Thank you very much.
Yusuf Gohar from University of Missouri. How many of these NG tubes were dislodged at home, and do you bridle your NGs before they go home?
Thank you. No, we don't bridle them, and the parents are actually educated to replace them and to test them. I think out of the 100, I think we had 5 dislodgements that were seen in emergency rooms. And they were seen in emergency rooms in critical access hospitals, so it's something not to be, to underestimate.
What babies qualify for this program?
It's a good question. So there's obviously a selection bias towards the ones who are better and do better. It's usually premature infants who I think only in quotation marks pathology that they have is respiratory distress. Babies with HIE or any neurological symptoms, we did not exclude them, but they usually need a G tube. And so the 3 that needed a G tube were the neurologically injured children, yes.
And have you thought about collecting any data regarding patient satisfaction regarding this program?
We will, and it's the families are actually very happy, usually from a subjective standpoint, and we might actually get a bias if we survey them. The ones who respond are usually the ones who are happy, but hopefully we can include all the data from that in the future. Yes.
Right.
Thank you.
Wonderful. Thank you.
Good evening. Thanks for the opportunity to present our work today. Which button is it? Sorry. Oh, the bigger one. We have the following disclosures. So the minimally invasive repair of pectus excavatum was first introduced in the 1980s and then to the broader surgical community in the 1990s. Following this introduction, one of the dreaded complications that has arisen is pectus bar displacement, which you can see radiologically depicted up here on the screen. This typically requires a surgical revision. Over the last 3 decades, surgeons have tried to improve their technique to reduce the risk of this, including stabilizing the bars with suture fixation, stabilizers, sternal elevation, and even bar bridging. With these surgical advancements, the rate of surgical bar displacement has decreased from around 20 to 30% to 2 to 5%. As part of the surgical dogma, activity restrictions have been imposed following pectus repair to help reduce the theoretical risk of bar displacement. These restrictions are typically in place for 3 to 6 months and include the cessation of sports, holding off on going back to school and even wearing a backpack, twisting motions, and even sleeping. With the advancements of surgical techniques, some surgeons have questioned the utility of restrictions on preventing pectus bar displacement. We chose to pursue this study to understand the implications that activity restrictions have in pectus surgery. It is important as it challenges a longstanding surgical dogma that ultimately may prove inconsequential. With this background, we sought to compare the effects of activity restrictions and no activity restrictions on the incidence of pectus bar displacement, and to compare the rates of complication between these two groups. To do this, we conducted a multi-center retrospective review, including 10 children's hospitals that were part of the Western Research or Pediatric Surgery Research Consortium. We included children that were less than 21 years of age who were undergoing pectus repair. Our primary endpoint was incidence of pectus bar displacement, which required return to the OR within 90 days of the index operation. We additionally divided our patients into two cohorts, activity restriction and the no activity restriction. Patients in the no activity restriction cohort were able to return back to activity as they saw fit. We then compared the incidence of bar displacement and other complications between these two groups. Overall, we included 532 patients in the study, of which a quarter were provided no activity restrictions. There was no significant difference in patient age, sex, height, weight, or pectus severity between our two cohorts. Interestingly and importantly, there was difference in the way they were repaired. Patients in the no activity group had significantly higher proportions of sternal elevation, cryoablation, and placement of one or more bar, while they had less pericostal suture use. Overall, the incidence of pectus bar displacement in our overall cohort was low. Additionally, we found no difference in the incidence of pectus bar displacement between the two cohorts. Next, we compared the incidence of readmission, reoperation, surgical site infection, bar infection, development of hematoma, and pneumonia. And again, we found no difference between the two groups. We then created a composite of all the outcomes that I had listed previously and found that overall there was no difference between the two groups in the development of any complication. When we interpret the results of the study, we should consider several limitations. First, it was a retrospective study and is inherently limited to bias. Second, we reviewed activity restrictions and not activity itself. As this was a retrospective review, we did not have a good way to determine what patients were actually doing when they went home, so we couldn't control for crossover. And importantly, there was technical differences between the two groups. However, the overall incidence of pectus bar displacement was very low among all patients, regardless of the surgery they had. To conclude, the modern incidence of pectus bar displacement is very low following the NUS procedure or the minimally invasive repair of pectus excavatum. We observed that physical activity restrictions following this procedure were not associated with bar displacement. Ultimately, if you do a good procedure, no matter how you do it, activity restrictions should not increase the incidence of bar displacement. Thank you, and I'm happy to take any questions.
We'll take questions from the audience.
Hi, Stephen Lee from Seattle Children's. Even though we were part of this study, I don't know the answers, so I'm going to ask the questions. One is, those that displaced, do you have an estimate time when they displaced postoperatively? And two, were there differences in the types of hardware that were used, specifically Pectus Blue versus the other types of hardware that can be used?
Yeah, that's a great question. On timing, they were all really within the first 6 weeks, all of the patients that did slip. We had one in the no activity restriction group that had a displacement and 7 in the activity restriction group. Interestingly, and this wasn't statistically significant just due to the size of the patients, but most of the patients that had bar displacement only had 1 bar compared to multiple bars. I don't know whether or not Pectus Blue was used to differentiate that hardware, but 1 bar was more commonly to slip than multiple bars.
Yuskar, University of Missouri. Any of your patients had bridges or 2 bars versus stabilizer?
Yeah, that's a great question. At this point, I think maybe they had 1 or 2 patients in the study that had bar bridging. We performed the study a little bit before surgeons at our centers have started using that. I imagine with bar bridging, the rate of pectus bar displacement will be 0 as the bars are connected to each other. But that's a great question.
And has your group considered looking at patient surveys or another way to calculate or another way to quantify patient activity? As we all know, patients may or may not take our suggestions on activity restrictions or none to heart. What they actually do might be substantively different than what we suggested.
Yeah, that's a great question. We have thought about doing that. We have set up a prospective study where we were going to interview our patients at initially post-op 1 month and 3 months follow-up. We just weren't able to get that off the ground, so it's something that's still potentially in the works. But with our retrospective study, we felt pretty comfortable that overall incidence of pectus bar displacement is low, and that children will likely self-regulate. If they're in pain, they probably won't keep doing what they're doing, but yeah.
Okay. All right, thank you very much.
Thank you.
Thank you for the opportunity to present today. We have no relevant disclosures. Enhanced recovery pathways have become a standard in adult surgical care, improving recovery and outcomes. But in pediatric surgical oncology, these pathways are underdeveloped, and there is significant variability in how perioperative care is delivered to children undergoing tumor resections, which can lead to inconsistent outcomes. Children with cancer are especially vulnerable and require effective perioperative care to resume critical cancer treatment. Faster recovery and reduced opioid use are key for children with cancer, not only for comfort, but to support early return to chemotherapy. Shorter hospital stays also reduce healthcare costs and alleviate stress on families. Most importantly, standardized care leads to safer and more equitable outcomes. This project also shows how multidisciplinary collaboration and quality improvement methods can transform pediatric surgical care. We have previously demonstrated the use of a similar protocol in abdominal cases and how it improved several key metrics while reducing complication rates. The primary aim of this study was to increase standardization of surgical care by employing the ERAS tumor pathway for children undergoing abdominal or thoracic tumor resections. We aim to have at least 80% of patients compliant with applicable process measures and sustained for 1 year. Over 15 months, we enrolled 57 patients undergoing 63 unique abdominal or thoracic tumor resections. We compared them to a historical cohort from 2015 to 2022. Our pathway encompassed 20 unique process measures spanning from the preoperative period to postoperative recovery. Preoperative measures included early patient and family education and the avoidance of prolonged fasting. Intraoperative measures included regional anesthesia, euvolemia, normothermia, and postoperative nausea vomiting prophylaxis. Postoperative measures included early feeding and mobilization, early removal of drains and lines, and multimodal analgesia. We used PDSA cycles to implement and critically review the pathway. We initiated cycle 1 early in implementation, as we noted a significant variability in documentation of key postoperative recovery metrics in the baseline cohort. We created this data-enabled progress note template to improve data consistency and reduce manual chart review burden. Cycle 2 was initiated when we noted that there was difficulty with adherence to the intraoperative normothermia requirements. We implemented a team-based huddle immediately preoperatively to align on normothermia, fluid goals, and analgesia. This resulted in significant improvements to normothermia goals. To the right is an example of the rubric that we utilized with specific metrics provided based on patient demographics that were input. Our process measure adherence over the study period was nearly 90%. When reviewing performance in key metrics, intraoperative fluid administration significantly decreased by approximately 50% in all cases. Intraoperative opioid use decreased significantly by approximately 33% in abdominal cases, but did not significantly decrease in thoracic cases. Postoperative opioid use decreased significantly in abdominal cases and in thoracoscopy cases. Time to regular diet was less than 12 hours in all cases. There were no nasogastric tubes placed in the ERAS tumor cohort. Even with the early resumption of enteral nutrition and the absence of nasogastric tube placement in the abdominal cases, there was no significant increase in rates of postoperative nausea and vomiting in all cases. Notably, there was a significant decrease in length of stay for 3 out of 4 surgical subgroups. When reviewing key balancing measures, there were no significant changes to all-cause or surgery-related 30-day readmission, ED visits, or complication rates for any cohort. In conclusion, implementation of the ERAS tumor pathway improved recovery in pediatric patients undergoing complex tumor resections. Importantly, our study validated the use of this pathway in thoracic cases. We saw reductions in opioid use, fluid administration, and length of stay, all without increasing adverse events. This project highlights the real-world impact of applying quality improvement methods in a multidisciplinary setting. We believe that this model can be scaled to other institutions and routinely adapted in pediatric surgical oncology. Thank you, and I'm happy to take any questions.
Yusuf Kohari, University of Missouri. So for NUS procedures, we use cryoablation routinely as standard of care for postoperative pain control, and now we're trying to move it to thoracotomy cases. So my question to you, have you used cryoablation for your thoracotomy cases?
Yeah, so that was actually an important aspect of the multimodal and regional anesthesia methods that were used in our cohort. So we are using cryotherapy for our thoracotomy cases.
So an impressively high compliance rate. And if you were going to attribute what the success was, do you think it was in the planning in terms of like getting all the engagement up front, or do you think it was the execution and like consistently checking to make sure that you were hitting these metrics?
I think both things really helped us with getting this adherence rate, but I think that the multidisciplinary buy-in was huge. You know, we had nursing staff in our clinics that were on board dealing with all of these patients, making sure that they were appropriately educated so they knew what was coming. And so I think adherence in that perspective really, it's also on the patients, not just on us. And so that really helped with families understanding why we were making them walk on day one and not being scared of those things. And then obviously our anesthesia team was involved, our APPs were involved in the creation of the progress note templates. And so that really helped us with making sure that each of these metrics were met all along the way.
Thank you.
Thank you.
Thank you very much for giving us the opportunity to present. Yeah, thank you. We have no disclosures. Achalasia, as you know, is a chronic esophageal motility disorder which is characterized by failure of lower esophageal sphincter to relax and absence of effective peristalsis. There are 3 types of achalasias by Chicago classification, and they're all different, but the treatment modality is essentially the same for all 3 of them. This disease is pretty rare, and symptoms tend to be very nonspecific, such as listed on a slide. A lot of times, and because the symptoms are nonspecific, most of the pediatric patients are being diagnosed late or misdiagnosed, for example, with gastroesophageal reflux disease as well as chronic asthma. If you have, as a child, if you have symptoms, and by the time you get diagnosis, on average, it takes about a year. We know the high-resolution manometry is the gold standard for testing. However, it's very challenging to do in kids. And historically, Lapheller has been the gold standard for treatment, but POEM has been emerging significantly, and we believe the reason why because parents are very educated, and if you give them a choice between Heller, myotomy, and POEM, always they will choose POEM. And we've started the program about 10 years ago, and we wanted to see how we're doing, what have we done, and what is our data looks like, and it's a retrospective analysis coming from single institution. So we've seen 101 patients with achalasia, primary achalasia, and operated. We've done about 110 POEMs. We've done 101 primary POEMs, and then we redid 9 POEMs, one of them 3 times for type 3 achalasia, which is very hard to treat, and they tend to respond poorly for treatment in general. These are the types are listed. Type 2 is the most common type of achalasia, hence the data shows that we have most of our patients tend to be type 2 achalasia. 4 patients are unknown type because the resolution, HRM was very hard to perform on those kids. So we opted to just use endoflip and do the procedure based on the ECAR score as well as the endoflip findings. If you look at our preoperative procedures, most kids, about 35 patients came to us with the prior endoscopic intervention, whether it was balloon dilatation or balloon plus Botox, and prior operation, 27 had prior operations, including Lapheller myotomy. Prior POEMs were done elsewhere, and a previous open hilar myotomy as well as gastrostomy tube placement for failure to thrive. Our youngest patient was 2 years of age, oldest 19. As time went on and as we got more experience, operative time was significantly shortened. As you can see, 351 minutes. This is the first operation, and now most of the cases are under 1 hour. We have followed up these patients closely. Most patients go home the next day. The 23 days is outlier. One child had complications, which I'll cover the next slide, and the duration of follow-ups median was 29 months. These are our complications that we had. We've had a total of 37 patients had complications. What we consider minor complications, these are intraoperative complications that we dealt with in the OR. Nothing happened beyond OR. For example, mucosotomy, pneumothorax, pneumobastinum, pneumoperitoneum. These are air that were evacuated during the operative time. We had no submucosal tunnel bleeding. We had 2 major complications post-operatively. Both had chest tube placed. I think one patient was early on in our experience. If it happened now, we'd probably remove the air through the needle decompression. And then one child had submucosal tunnel leak, which required chest tube placement, and that's the child that stayed 23 days. Looking at the long-term complications, recurrent dysphagia in 7 patients, which were dealt with pneumatic dilatation, and 11 patients had essentially biopsy-proven reflux that we treated with proton pump inhibitors. We've had 9 patients who failed, and we had to redo them. One of them, 3 times as I said, and this patient had a type 3 achalasia. If you look at how successful the operation was, 94 patients had essentially clinical, after initial, it was a successful operation in 94 patients, and about 16 patients required reoperation, or not reoperation, reintervention. Single balloon dilatation in 7 patients, and as I said earlier, 9 patients had a repeat poem. So in all those patients, after second intervention, had 100% improvement. And we follow up these patients based on the endophthalmic findings intraoperatively, endoscopies, as well as ACAR scores, which we clinically evaluate initially as well as every time we see them. So we believe POEM is a safe, effective, and durable treatment for pediatric achalasia, even though there's a pretty steep learning curve. In our results, in our experience, it demonstrates superior outcomes compared to lapellar myotomy. Obviously, every patient is different. You have to approach them as a multidisciplinary approach. And obviously, longitudinal studies are essential to validate these promising results and refine treatment protocols. Thank you very much.
So a couple of quick questions. Your rate of achalasia seems higher than what I would expect for your area. You're doing about 10 patients a year, is that correct?
Correct. So we have our initial experience, we had a patient mom who, our couple of first patients, one of the moms got heavily involved with us. So essentially, if you hear achalasia on a web, you end up at Children's because she educates them and most of them come to us. So we have patients from Australia, South Africa, and various other countries, and besides all over Northern America, and they end up coming to DC.
So my question was going to be, have you looked at where your patients come from? So
Yes.
it sounds like a very interesting referral pattern.
Yeah.
And then how many of your surgeons actually perform this procedure?
2 of us.
Okay.
You guys are always pushing the envelope. That was really interesting. I was wondering, is there anyone you would not offer POEM to? Is there something about some of any type of anatomic or the type of achalasia or the length of symptoms, or anything that you would say this is not an appropriate patient for this procedure?
If you have achalasia and it's safe to do, then we'll do the procedure. Now, a lot of kids are misdiagnosed. We've had consultations with kids who had, for example, Nissen fundoplication and then diagnosis of achalasia, or Nissen with door fundoplication that twisted the esophagus, and now they've diagnosed achalasia based on HRM. But once we took down the wrap, child had symptomatic improvement. So those kids, you have to be careful, especially if redos. It's pretty hard to offer a POEM if it's not helpful. But POEM is pretty safe because esophagus 360, and you can basically cut on the muscle anywhere you go if you stay away from the previous cut. And it's easy to find the healing part once you put endoscopy. You can see where the previous cut was based on whether your mucosotomy or whether you entered the esophagus from the inner part. So normally, if anesthesia is able to be induced, we'll offer the POEM procedure. And like I said earlier, majority of patients, I haven't met anyone who does not want a POEM first before they even offer. They do not want a Heller myotomy anymore. It's hard to convince them. Even the 2-year-olds, we attempted and it was successful.
Someone from the floor wanted me to follow that up with, why don't you think they need a fundo? You did have a fair number of kids who had reflux and ended up on being treated for reflux.
You mean the reflux rate?
No, I mean, when you do your procedure, your POEM procedures, obviously you're not doing a fundo. Classically, when we've done Hellers, we did some type of fundoplication partly to protect the repair or the myotomy, but also because the feeling was when you made the sphincter incompetent, you were going to have secondary reflux.
Correct. Interestingly, if you look at adult data, which we most refer to because there's not a lot of pediatric studies, in adult data, 54% of patients after POEM had reflux. In our data, we follow up patients, we scope them every year, and we do biopsy on every child that we scope. In our patients, we have about 11% refluxes, which is significantly lower what current literature shows, even in pediatric population. With lob-Heller myotomy, reflux rate is about 17%, if you look at the data. So it's still lower with Heller POEM procedure in pediatrics, and maybe physiology is different in pediatric population, which I'm sure it is, compared to adults. So our rate of reflux is significantly lower. We discharge patients on anti-reflux medications, but we stop after we scope them at year.
Thank you.
Thank you.
Thank you. I have no disclosures. Pediatric vascular disease encompasses a wide spectrum of pathologies that require complex management. And there's been an increase in the pediatric vascular disease burden, partly due to more complex endovascular access, complicated oncologic procedures, and also an increase in penetrating trauma. This is also in the context of there being a decrease in the vascular exposure in the general surgery training paradigm. We thus were interested in better understanding the landscape of pediatric vascular disease management. And we had two aims: to one, define the scope of pediatric vascular surgery practice, and two, to identify any challenges in the provision of care. We developed a 21-item questionnaire that was administered to pediatric surgery division chiefs or their proxies at United States Children's Hospitals in 2024. The surveys consisted mainly of questions on their background and focused on practice patterns and also resource utilization. And we also included the perspectives of the respondents. We performed a descriptive study and performed quantitative and qualitative analysis. We identified a total of 182 pediatric surgery departments and had 138 complete responses, which gave a 76% response rate. 85% of pediatric surgery fellowship programs were included, and 61% of freestanding children's hospitals were also represented. 88% of respondents were from institutions that had trauma centers. We first looked at access, and then we looked at the procedures that were performed. 80% or more of the institutions had a vascular surgery call schedule, had a vascular surgeon that was available 24 hours a day, 7 days a week. And they also gave vascular surgeons routine privileges, and they were able to bill for their vascular consultations. 77% of the institutions performed ECMO cannulations, and of note, 90% of these cannulations were done by pediatric surgeons and not adult vascular surgeons. 66% had vascular trauma care, and 67% had the capacity for microsurgical techniques. Of note, the capacity to do ECMO cannulation and vascular trauma care was associated with having a trauma center present. The most commonly indicated indications for adult vascular surgery consultation were there being major vascular trauma, the need for endovascular techniques in reconstruction, and also complex oncologic cases. Barriers that were identified to expanding vascular surgery coverage and access included availability, staffing, cost, the adult vascular surgeon interest, and that tied into the willingness to operate on small children, geography, such as being attached to an adult hospital, and also inadequate volume. We quantified perceptions using a Likert scale and saw that a very small minority believed that vascular surgery should remain, or vascular surgery in pediatric patients should remain in the hands of pediatric surgeons alone. Put in other terms, there was a recurrent belief that the standard pediatric surgeon armamentarium lacks adequate vascular expertise. About 42% of people were satisfied with their division's ability to care for pediatric vascular problems, and about 21% saw that if it weren't for logistic impediments, they would seek vascular surgery consultation more frequently. There are limitations to this study in that it's observational, and any survey study is also subject to recall bias, and not all institutions were included. In seeing that there is institutional variability, in order to be able to bridge any gaps in care into standardized care, it may be necessary that we form more collaborative agreements and arrangements. To this effect, the Society of Vascular Surgeons and APSA have a pediatric vascular initiative. Our local institution has collaborations with adult vascular surgeons where we provide longitudinal care. And in bringing in our vascular surgeon colleagues, we would want to know their perspectives as well. So next steps would include performing a similar study amongst adult vascular surgeons. And we would hope that the results from this study and future studies would help support more collaborations and support local initiatives such as at the University of Texas, Houston, where they are building a pediatric vascular surgery database. Overall, we saw that pediatric vascular practice patterns are variable, and it is very much tied to the local resources. In order to standardize and optimize care, it is necessary, or most likely necessary, that we will need to form more collaborative agreements. Thank you for your time, and I'm happy to take any questions.
Gilchrist, Brooklyn. I think you're dealing with a generational issue, not a specialty issue. All of us who are 50 and above or 60 and above are not at all afraid of doing vascular cases. We'll put anything together, but I think the younger folks are not as willing to do so. So I think when you do your next study or you look into this in more depth, you got to look at the generational differences among us as pediatric surgeons.
I think that's a good point. You know, in this study, we did not break down the years of practice, and so that would be interesting to see if there's any sort of association between surgeon comfort and how long with these cases and the years of practice as well.
Did your study examine if, for example, there was a vascular issue and needed a quote vascular surgeon, if the vascular surgeon would actually come to the children's hospital versus having to transfer that patient to that surgeon's hospital?
Yeah, that is a good question. We did not specifically ask that component. The understanding was that when we asked about vascular surgeon access and their privileges, was with the understanding that they would be coming to the children's hospital. But again, we didn't specifically ask in that way.
And one more follow-up question. You said that 90% of the ECMO cannulations were, or 90% of the group surveyed said the pediatric surgeons did the ECMO cannulations, but you did say that about 31% will consult the adult vascular surgeons for some of those ECMO cannulations. Can you talk about that a little bit more?
As far as details as to when?
Yes, when they would consult adult vascular surgeons for ECMO.
Yeah, for ECMO, the responses were mainly due to surgeon comfort and to the complexity of the case. So for most cannulations, pediatric surgeons felt uncomfortable, or felt comfortable, I should say, and there were vascular surgeons were roped in cases that were more complicated, so things such as lower extremity rather than neck cannulations. One thing that we do think would be also interesting is decannulations, especially for extremity access, where sometimes you may need more reconstruction. So I think that would be interesting in our future studies as well.
Thank you very much.
Good evening. My name is Nitin Sajankila. I'll be presenting on behalf of Cleveland Clinic Children's and the Pediatric Surgery Research Collaborative. Non-operative management, or NOM, is an alternative to appendectomy for uncomplicated acute appendicitis. Recent studies have shown that non-operative management is feasible and safe in children. However, utilization has been variable, and at present, no consensus exists among surgeons as to when or how it should be used. Studies have also shown that up to 50% of patients and families are interested in an antibiotics-alone approach. However, surgeons' attitudes and their approach to non-operative management are unclear at present. To explore surgeons' preferences and practices, we developed an anonymous electronic survey and distributed it via email to attending pediatric surgeon members of APSA and AAP, with internal reminders being sent out to collaborators at PEDS SRC institutions. In total, 433 attending pediatric surgeons responded to our request with a response rate of 41%. The median years in practice was 14, and respondents to our surveys worked at either a freestanding children's hospital or children's hospital within a general health system in an urban environment, and about half were affiliated with an ACGME accredited fellowship. 80% of our respondents performed anywhere from 21 to 100 appendectomies per year, yet non-operative management was infrequently utilized, with 84.9% of respondents using non-operative management less than or equal to 5 times per year. Still, a majority of respondents felt they had some experience with non-operative management. Respondents without experience were in practice longer. However, no difference in utilization was found based on hospital type or affiliation with a fellowship. We began our survey by asking how often is non-operative management discussed when a patient's eligible. We found that 42% of our respondents discussed it always or most of the time. In contrast, when asked how often is non-operative management actually offered when a patient's eligible, only 28.6% answered always or most of the time. We then asked how often do surgeons actually initiate that discussion of non-operative management themselves. 61.1% routinely initiated that discussion, and about half of these respondents discussed it in a balanced fashion, carefully going through the risks and benefits of each approach. 38.9% did not routinely initiate the discussion of non-operative management, but still a majority of these respondents, when prompted by the family, discussed it in a balanced fashion. And none of our respondents automatically directed patients towards antibiotics alone. We then asked what were the major reasons for either offering or not offering non-operative management when indicated. With regards to top reasons for offering, this included patients like having choices, opportunity to avoid an operation, and that non-operative management resulted in a quicker recovery or return to activity. With regards to reasons against offering, top reasons included that recovery was faster after an appendectomy, recurrence rate was high after non-operative management, that antibiotics alone prolonged hospital stay and antibiotic course, and that ultimately surgery was better for patient throughput. Given that various studies have looked at several different criteria to determine eligibility for non-operative management, we wanted to know what surgeons out in practice were actually utilizing. We found that our respondents used absence of appendicolith, duration of symptoms to determine eligibility, but there was much less consensus with regards to radiographic findings, laboratory values, and age, for example. Compared to the Midwest Pediatric Surgery Consortium's study and the eligibility criteria that they utilized in that 2020 study, our respondents were comfortable using a lower age limit than previously studied, and only 62% required a strict size cutoff for their appendix. We also asked our respondents what their opinions were regarding observation prior to discharge, as well as follow-up timing, and found that 65% of our respondents wanted their patients to be observed for at least 24 hours prior to discharge, but a minority were comfortable with discharging immediately on antibiotics if certain criteria was met. With regards to follow-up timing, half of our respondents felt that the patient should follow up with the pediatric surgery team within the weeks of discharge, but some were comfortable with follow-up with PCP only or even a phone call. With regards to how success was defined, a majority of our respondents felt that tolerance of PO, absence of fever, and resolution pain or improvement of pain mattered. However, interestingly, less consensus existed for vitals or laboratory markers to be used. And then when asked, how likely are you to change your practice in response to more data, 58.9% said definitely yes or highly possible. In conclusion, surgeon perception of non-operative management remains largely negative. Wide variability in valuation of risks and benefits of non-operative management exists, In fact, many surgeons are comfortable deviating from previously studied criteria. And finally, most surgeons are comfortable with discharge after 24 hours, but no consensus exists on follow-up timing after non-operative management. I'd be happy to answer any questions.
So I had one question. You said, or you reported that about 40% of surgeons said that they offered it sometimes. Were there any questions on, related to if they offered it sometimes but not routinely, to whom did they offer it? For example, was it for more medically complex patients or inconsistencies in the clinical presentation, something like that?
Yeah, we didn't quite capture that level of granularity, and that's a completely fair question. There were some, for all of our questions, we left kind of, or for almost all of the questions, we left an open box, and there were definitely some that described that kind of situation. But there were a lot of people who also answered in that other box based off of kind of families' concerns and questions and how that, and that's another aspect too, is you'll encounter different families who push you one way or the other, and how you respond to that could also vary.
Please.
Agostino Piero, Toronto. As you know, we published recently the API trial results, and this may have an effect, obviously, on the view of people who have been interviewed, and I suppose your survey is preceding the publication of this large trial. So what is your opinion about then the negative approach towards the non-operative treatment will be even less accepted if you would do the survey now?
I think that's a fair question, and actually, I almost wish we had staggered this a little bit with the API trial results, because we didn't know that was going to be published at that time point. So you could almost repeat the same project and see if what impact the API trial had. At the same time, compared to the Midwest Pediatric Surgery Consortium study, the failure rate was fairly similar. Just the definition of the comparison groups essentially changed. So I wonder if the camps that believe that non-operative management works might not change their answers, and the ones that already don't believe in it are just going to be more cemented in their beliefs.
Sure.
But it's a fair question.
Thank you.
Yeah, hi, Rose in Cincinnati. Fascinating study. I feel bad that I'm probably one of those who didn't respond to that survey email, but you know, like the thing first thing that's startling is the low number of people who actually talked about it. And you know, I'm not a big fan of not doing the thing that I do, which is do operations to help people. But I talk about it in 100% of times. If you don't bring it up, you know, you write, we discussed risks, benefits, alternatives. You did not discuss alternatives unless you discussed this as an alternative. So maybe that's like a call to arms for everybody in the room. Like, you got to talk about this with your patients. But you know, the words balanced, had a balanced discussion, and the words offer, like, I find those a little bit, I struggle with that, because I don't really believe I've got equipoise on this issue. You know, I do surgery that has a very, very, very high success rate and very low morbidity rate. And like, it works. That's another word that I struggle with, because yeah, sure it works. And we started, by the way, doing non-operative management, not of simple appendicitis, but of complex appendicitis. You know, appendicolith, big bucket of pus in there. We're cooling that off in a lot of scenarios, and that can succeed in the short term. And then in general, we follow that up with an interval API, and then, you know, there's discussion about when you need to do that or don't do that. But so there's no question it's gonna work in the short term. My definition of work is work in the long term. So again, I don't feel that surgeons have equipoise on this issue in reality. I don't think that I have to offer, but I think it's incumbent upon me to recommend to my patient what I would do for my child. And that, I think, is really where the difference is. And again, I don't know if that's generational or what, but I really think that that's our responsibility.
Thank you. I'd have to say that me participating in this like has altered even my own approach. Previously, I wouldn't even bring it up unless the families brought it up, because our culture at my home institution is surgery first. But now, as a result of this, I do bring it up and kind of offer my thoughts on it. So that's at least been a personal change for me. You'd also probably appreciate this. We had, when developing the manuscript, like, this does not represent all of the opinions of all the people who contributed to this. The choice of words was fascinating. Everyone had an opinion on whether we were like phrasing this in a way that was too positive or too negative.
Last question.
Ramin Jamshidi from Phoenix. Thanks for your presentation and a topic that's generated so much renewed interest since about 2010, I think. My question is, did you ask about what people's comfort level was or their self-rated knowledge or awareness of the literature? And if you'll indulge me, I'll insert this comment. My motivation about the question is that we're coming up on 100 years since penicillin was discovered. We've known since World War II with seamen in submarines that you could treat appendicitis with antibiotics. And there's been decent literature since the 60s that said that your rate of non-operative treatment success, meaning resolution of acute inflammation, infection, not requiring operation, to Dr. Rosen's point, was over 90%, and that the recurrence rate was 30 to 35%. And in the last decade and a half, we've repeatedly gone about and re-demonstrated that. So, did you ask that question? How familiar are you with literature about non-operative management of appendicitis rather than just how you feel about it?
We did not. To some extent, we assumed that they had been familiar, but that's a fair question, and I think in subsequent surveys, which we'll probably end up having to do given API trial and things like that, that's a fair question.
Thank you very much.
Thank you to ABSA for allowing us to present our work today. We have nothing to disclose. Inguinal hernia repairs are commonly performed in pediatric surgery. In open repairs, sacrosection is often performed with the thought that it helps prevent hydrocele formation. However, sacrosection is rarely performed in laparoscopic repairs. The effect of surgical technique on postoperative hydrocele is not well described in the current literature. We sought to conduct this study to help surgeons balance competing risks. If you leave the distal sac in place, there's a risk of postoperative hydrocele formation and possible need for reoperation. If you resect the distal sac, there is risk of injury to the cord structures. In this study, we assessed the impact of surgical technique on incidence of postoperative hydrocele requiring intervention following inguinal hernia repair. We conducted this study via a retrospective chart review of pediatric patients that underwent inguinal hernia repair across 21 centers between January 2017 and December 2019. The primary question of our study was to look at incidence of postoperative hydrocele for open versus laparoscopic inguinal hernia repair. The secondary question was to look at postoperative hydrocele requiring intervention incidence for open inguinal hernia repairs based off whether or not they performed a distal sacrosection. Approximately 8,400 patients met inclusion criteria for our study. Just over 2/3 of the operations were performed open. In comparing demographics between the two cohorts, we found that laparoscopic patients were slightly younger, weighed less, and were more likely to have a VP shunt, whereas slightly more patients in the open cohort were born prematurely. Postoperative hydrocele requiring intervention developed in 0.3% of all patients in the entire study, with median time to hydrocele intervention at 5 months. In the open group, 78% had distal sacrosection. In the laparoscopic group, none had distal sacrosection, and less than 1% had sac inversion with ligation. When looking at incidence of postoperative hydrocele, there was no difference between the two groups, with the rate in the laparoscopic group being 0.4% and the rate in the open group being 0.3%. We then looked specifically at those that underwent open inguinal hernia repair. 78% had distal sacrosection, and 22% did not. We did not find a significant difference in postoperative hydrocele formation between those that did and did not have their distal sac resected. We then performed a binary logistic regression to identify risk factors for postoperative hydrocele requiring intervention. Laparoscopic repair and distal sac resection were not found to be risk factors. However, having a VP shunt in place was associated with an 11-fold risk of developing a postoperative hydrocele, while being larger at the time of operation appeared to be protective. Limitations of our study include the fact that it was a retrospective chart review that only captured patients with postoperative hydrocele needing re-intervention at the same hospital as their index operation. We also did not evaluate incidence of cord structure injury at the time of the index operation. In conclusion, the incidence of postoperative hydrocele that requires intervention after pediatric inguinal hernia repairs is low, at less than 0.5%, regardless of surgical approach. Leaving the hernia sac in place was not associated with an increased risk for postoperative hydrocele development, and resecting the hernia sac may be placing the cord structures at unnecessary risk. Thank you, and I'll take any questions.
So my question was, when you talk about distal sac resection, how was that specified? I understand you did it across multiple different institutions. When given instruction to each institution on how to do that, how was that quantified? Was that by op-note, by pathology? Because the rate of distal sac resection strikes me as somewhat high.
Yeah, with this being, this was a multi-center study. How we defined it was within the operative note when going through the chart review. If they mentioned that they performed that, then that was included in that cohort.
Did any of these patients have concurrent hydroceles noted in the preoperative evaluation or during the surgery?
So that's another limitation of our study. We did not capture whether or not the patients during the index operation had a known hydrocele and whether or not that was intervened on. But that's certainly something that we can look at in future studies. Okay, thank you.
Thank you.
Thank you for the introduction. These are our disclosures. Over 38,000 pediatric inguinal hernia repairs are performed per year. And as you all know, this is done either laparoscopically or openly. Laparoscopic recurrence is reported at anywhere from 0.6 to 9%, and open recurrence is reported anywhere at 0.5 to 2%. As has been noted repeatedly in adult hernia studies, surgeons with higher volume have improved outcomes. Because of this, we wanted to know, does pediatric surgeon yearly inguinal hernia repair case volume affect hernia recurrence rates? This was a multi-center retrospective cohort review that occurred over 3 years at 21 centers. 207 pediatric surgeons were included. There were over 7,000 cases. Patients were included if they were less than 18 years of age at the time of their operation. They had it was their initial hernia repair, and if only a single technique was used during the case. Surgeons were categorized by their volume each year. So 207 surgeons over 3 years accounted for 621 surgeon years. They were categorized based on their volume and were considered high volume if they were in the 4th quartile of case volume, and not high volume or low volume as we'll refer to in the presentation if they were included in the 1st through 3rd quartile. We looked at all inguinal hernia repairs, open pairs alone, and laparoscopic pairs alone. And our primary outcome was inguinal hernia recurrence within 3 years. So when looking at all hernia repairs, high volume was considered surgeons who performed more than 22 cases per year. And as you can see, surgeons performed anywhere from 1 to 92 cases in a year. There were 178 low volume surgeons who performed 49% of cases, whereas there were only 68 high volume surgeons who performed 51% of cases. Low volume surgeons had a recurrence rate of 1.6%, while high volume surgeons had a recurrence rate of 0.9%, with 1.7 times more likely recurrence in the low volume surgeons. When looking at just open cases, surgeons who performed more than 17 cases per year were considered high volume surgeons. And this ranged from 1 case per year all the way up to 86. 163 surgeons were considered low volume, performing only 42% of cases. 50 surgeons were considered high volume, and they performed 58% of cases. Low volume surgeons had a recurrence rate of 1%, while high volume surgeons had a recurrence rate of 0.7%, and this difference did not reach statistical significance. When looking at laparoscopic cases, surgeons who perform more than 10 cases per year were considered high volume, and surgeons range from 1 case per year to 39 cases per year. 163 surgeons were considered low volume, only performing 37% of cases, while 58 surgeons were considered high volume and performed 63% of cases. Low volume surgeons had a recurrence rate of 3.7% versus the 1% for high volume surgeons, and were 3.7 times more likely to have a recurrence. There were some limitations to our study. Surgeons could be high volume 1 year and low volume another year because of the way that we classified them. Recurrence was only known if these patients returned back to the operating hospital. We weren't able to account for surgeons joining or leaving a practice in the middle of the year, and we could not account for a surgeon's cumulative experience or their number of years in practice. We did not have this information. Nonetheless, surgeons who performed less than 22 hernias per year were 1.7 times more likely to have a recurrence. And when considering just laparoscopic inguinal hernia repairs, low volume surgeons were considered to have 3 times higher recurrence rates, while no difference was seen in the open cases. This just points to how maintaining sufficient volume is important in maintaining skills and minimizing hernia recurrences, which is exacerbated within that laparoscopic skill set. Thank you to all the institutions and the many people who contributed to this, and I'll take any questions.
Hey, Brian Gulak from Rush University. I really like this study. I think it's driven by what we already know, which is that early in your laparoscopic inguinal hernia numbers, your recurrence rate's higher. The one thing that was interesting you did is you chose kind of a priori your Q4 as your high volume versus low volume. And there's statistical modeling you can do where you can actually figure out the inflection points of these things. So you actually have a better idea, okay, what's the actual cutoff of when you actually move from that low volume to your high volume, or when your actual recurrence rates drops. Did you guys do any of that modeling? And if not, I'd strongly recommend it for the paper because I think that's really important to know for us. Okay, like when you chose a priori 22 cases, it definitely shows a difference, but it really might be 12 cases.
Yeah, thank you for the question. We did not do any of that modeling in this even for the manuscript at this point, but that is something we could definitely look into to really strengthen the data that we have here. Thank you.
Elliot Pennington, Grand Rapids, Michigan. Your cutoff, especially for laparoscopic high volume, seems shockingly low. How do you recommend that we use this data? Do you funnel hernias to only high volume surgeons in a similar way that we've argued for sort of best, referring oncology cases, say, to high volume centers? Thanks.
Yeah, thank you for the question. It is a low number, mostly because of the way that we defined it within the surgeon population that we had. If you actually look at some of the studies that are out there, there's one study that used CUSA modeling that indicates 17 as the number of cases for laparoscopic surgeons, but we were limited in with what our data set was. But to your point, I do think that this points out the importance of maintaining those laparoscopic skills, and if you're someone who's not going to do many of your cases laparoscopically, then maybe you consider funneling laparoscopic cases to the surgeons in your institution that are going to be doing that.
Pete Manetchi, Nemours Children's Health, Delaware. Maybe I missed it, but did you do any multivariable modeling here, in particular controlling for age, as recurrence rate tends to vary depending on the age the child's hernia is repaired? That would be, if I missed it, I'm sorry, but if you didn't, that would be a really important thing to factor in to see if these findings actually hold up if we factor in age.
Yeah, we definitely could do that within the whole data set. That wasn't done within this particular abstract, and there was quite a variability in age where most of the patients were much younger in this population, but that's something that we'll look at.
Hi, Jason Robertson, Cleveland Clinic. My question is if you looked at the technique people used when they were repairing or doing laparoscopic hernia repairs, because I'm aware of at least a couple large consortium studies that haven't been published or presented yet, but that have shown that if you do a laparoscopic repair and you cauterize the ring and use a permanent suture, your recurrence rate is the same as doing an open repair and much lower than if you do a laparoscopic repair without those. So I wonder if somebody just getting into starting to do laparoscopic hernia repairs is omitting those, now we know, important aspects of the technique from their surgery, in which case the recurrence rate could have more to do with the way they do the surgery than their experience with it.
Sure. That is something we could look at within this data set too. It was accounted for when the data was collected, but in the interest of ensuring that we did not underpower our study during, for this particular study, we didn't limit our patients by that, but that's something we could look at.
Thank you very much.
Thank you. All right, thank you again for the introduction. We have nothing to disclose. Up to 12% of pediatric trauma involves chest injury. While hemothorax in pediatric trauma patients is rare, it does come with some significant morbidity. Adult studies have suggested that a threshold of 300 milliliters of hemothorax measured on cross-sectional imaging necessitates a drainage procedure, but these studies haven't been repeated in the pediatric population. So we set out to determine what hemothorax volume is associated with need for a pleural drainage procedure in children. This was a retrospective chart review that occurred at 2 trauma centers over approximately 10 years. We included patients who were under the age of 18, who had imaging diagnosed traumatic hemothoraces. They were included in the volume measurement if they had cross-sectional imaging during their initial ER workup prior to a drainage procedure. They were excluded if imaging was not available, if a pleural drainage was completed prior to their imaging, or if pleural drainage was done at an outside facility, and if they died within 24 hours of hospitalization. We utilized receiver operator curves to determine the hemothorax volume threshold for chest tube placement. We used Mergot's formula to determine our volumes, with D being the greatest depth and L being the greatest length. We had nearly 400 patients with traumatic intrathoracic injuries. There were 50 with traumatic hemihemothoraces. 22 of these were successfully observed. 6 fell within our failed observation group and were ultimately included in the chest tube group. 22 were initially treated with chest tubes. Of those patients, the ones that received additional procedures were for reasons other than their hemothorax. When looking at our patients who were successfully observed in the green and all of our patients who received chest tubes, injury severity, thoracic injury severity, hemothorax volume, and hemothorax volume by height were significantly higher in the chest tube group. When looking at just the patients that failed observation compared to the patients in the observation-only or successful observation group, injury severity score was significantly higher. Hemothorax volume, volume per height, and volume per weight were higher but didn't reach statistical significance. We had no readmissions at 30 days or 1 year. We had no reported pneumonias or empyemas in any of our patients. The 3 additional chest tubes that were placed, as mentioned earlier, were not related to the hemothoraces. Our patients who failed observation failed on average at 27 hours after presentation. Chest tube patients had longer ICU lengths of stay and hospital length of stay and were more likely to be intubated. Additionally, those patients that failed observation also had longer ICU and hospital length of stays. When looking for a volume threshold, when we initially prioritized not missing need for a chest tube, we found that 20 milliliters was an appropriate cutoff for our patient population. But because we had no complications in our failed observation group, we decided that we wanted to prioritize not misidentifying patients who were successfully observed into the chest tube group and found that 55 milliliters was a more appropriate cutoff. We then repeated this by weight to account for different varying sizes of children and found that 0.4 milliliters per kilo was an appropriate cutoff for prioritizing not missing need for a chest tube in our group. And 1 milliliter per kilo was an appropriate cutoff if we were prioritizing not misidentifying successfully observed patients into the chest tube group. There were some limitations to our study. 80% of our patients did have concurrent pneumothoraces that contributed to their decision making. And this was inherent limitations to the retrospective study was that we could not determine how decisions were made based on the pneumothorax versus the hemothorax and had to just prioritize where there was documented that the hemothorax had grown. Additionally, there is potential for underestimation of the actual hemothorax volume through Mergot's formula because it doesn't account for the most lateral and most medial portions of the chest. But in conclusion, we're presenting the largest pediatric hemothorax study. Additionally, not all of our traumatic hemothoraces needed a drainage procedure. Also, cross-sectional imaging can be a volume. Cross-sectional imaging volume calculations can help with decision-making, and we determined with our cohort, 1 milliliter per kilo hemothorax threshold could be a useful adjunct to clinical decision-making within the clinical picture. And as you all know, kids are not little adults. Unlike what is feared in the adult population, we did not note any empyemas or fibrothoraces in our patients, including those that had delayed drainage procedures. And additionally, no patients required additional chest tubes or operations for their hemothorax, even in those patients who had delayed drainage procedures. Thank you. I'll take any questions.
How did you define failure in terms of like those who did not have a chest tube initially? Was it just increasing oxygen requirement or increased size of the hemothorax?
We defined it based on what the initial documented plan was in the note. So those patients who were had a documented plan that said they were going to be observed and then later on received a chest tube were defined as failed.
Did you, like when they received a chest tube, why did they receive a chest tube?
Yeah, so they only were considered failing for their hemothorax if they were documented to have an increasing size of hemothorax. If they were documented solely to get a chest tube because of their pneumothorax, that was not considered to be a failed observation of a hemothorax. But many of the notes commonly just noted both the pneumothorax and hemothorax, and that was hard to decipher.
Yusuf Gohari, University of Missouri. One of your slides had chest tube / pigtail catheter for a traumatic hemothorax. So some of your patients received a 10 French pigtail catheter to treat a hemothorax?
That is correct. It was a very small portion of them. There were, I think, about 4 in the entire population, but there were some that received a pigtail catheter.
So when I saw that slide, it reminded me of a randomized control trial. I believe it was Phoenix and University of Nebraska in adults. And in their randomized control trial in traumatic hemothorax, they claimed in their paper that there was no difference between a pigtail catheter and a standard 36 French chest tube. I was surprised to see that in your paper as well. Thanks.
Thank you.
And were these isolated thoracic traumas, or were they potentially multi-trauma?
They were potentially polytrauma.
Polytrauma.
Yeah.
All right, thank you very much.
Good afternoon. Thank you for the opportunity to present today. Our main disclosure is that the original clinical trial that this study is based on was funded by the Patient-Centered Outcomes Research Institute, or PCORI. So our current treatments for pilonidal disease are not as efficacious as we would like. For example, the rate of recurrence for patients treated non-operatively is estimated to be as high as 55%, and even for patients treated via operative intervention, the risk of recurrence is still estimated to be between 30 to 40%. These high recurrence rates lead to increased morbidity, which can be manifested as painful wounds, foul-smelling discharge, missed days of school and work, and withdrawal from activities. Previous retrospective studies have demonstrated that a higher number of previous episodes of pilonidal disease and an increased BMI are associated with an increased risk of recurrent disease. The objective of this study was to use prospectively collected data to identify patient factors independently associated with disease recurrence. As I mentioned previously, most of the data available on recurrence risk is based on retrospective studies. So our goal was to use our prospectively collected data set to identify recurrence risks. In order to get to this study, I'm going to briefly share the previously published results that led from the randomized controlled trial which led to this study. First, the original publication reported on the primary outcome of disease recurrence in the study of 300 patients. 1-year disease recurrence was significantly lower in the laser epilation group compared to the standard group. The second study explored the heterogeneity of treatment effect based on patient and family characteristics. We looked at a set of pre-planned variables to assess heterogeneity based on the previous literature. These are the pre-planned variables listed above, and there was no significant heterogeneity of treatment effect based on these pre-planned variables. We also looked at some exploratory variables which we predicted could alter the effectiveness of treatment and have a heterogeneity of treatment effect. These included race and ethnicity, health insurance, and income. We saw that patients of all other racial and ethnic groups did not have the same effect of, did not see the same effects of laser epilation as non-Hispanic whites. Also, patients with public health insurance did not have the same benefits of laser epilation as those with private insurance. This brings us to the focus of today's presentation. We conducted a planned secondary analysis of the RCT to identify variables associated with disease recurrence. We did multivariable regressions for disease recurrence at 1 year and created 3 models. One model including all the variables included in the HTE analysis, one model with an interaction between laser and race and ethnicity, and a third model with an interaction between laser and health insurance. We chose these interactions because they were significant in our HTE analysis. The only variable independently associated with decreased disease recurrence was laser hair epilation. In the model, which included race and ethnicity, the results were not significant and were similar to the overall model. However, in the model that included insurance type, the interaction remained significant, and these are what the results looked like. As you can see, patients with private health insurance who received laser epilation still had a decreased odds of 1-year disease recurrence. However, patients with public insurance did not have the same decreased odds of disease recurrence when receiving laser epilation. In conclusion, laser epilation is an effective treatment in preventing 1-year disease recurrence, pilonidal disease. However, the effect of laser epilation may differ based on insurance status. Therefore, future studies must focus on the heterogeneity of treatment effect of laser epilation, and we must develop strategies to mitigate these disparities. Thank you.
Hi, thank you. I was wondering if there was a difference between the number of episodes of laser hair ablation between the 2 insurance groups.
Between the 2 insurance groups?
Yes.
I am not sure. Everybody received the same number, or was supposed to receive the same number, but one of the challenges of the study was it took place during COVID. So there's a potential for missed sessions of laser hair epilation.
To follow up on that, it'd be interesting to know the percentage of people that the private insurance actually paid for the laser, because you might see that it wasn't paid in either direction, so that would be something to look at.
Absolutely, and that's a focus of future studies, is making sure that patients with public health insurance do not have barriers to care compared to the private health insurance and privately insured patients.
To follow along with that same theme, I think it would be helpful to know the strength of the treatments that they got, the number of treatments that they received, because as we know, some patients will require 2 or 3 treatments, and some patients might require 6 or 8 in order to have the same effective response.
Absolutely. It varies based on skin color, Fitzpatrick type, et cetera. So we definitely have to make sure that everybody is receiving the necessary number of treatments, and it might not be the same.
All right, thank you very much.